Welcome to all our members and those members of staff who have also joined us today. I'm really pleased to be here. As Sam mentions, I am the chair of University Hospitals Southampton. I joined in July, at the beginning of July this year, but I am a returnee to UHS. I was previously on the board as a non-executive director from 2016. And then became the deputy chair in January 2020, and then left in September 2020 to take up a role in NHS England. So really pleased to be back, and really pleased that we're really looking forward to working with all of you on our vision to be a world-class organisation delivering world-class care. And I hope you will find this afternoon interesting. We have got a range of speakers lined up to take you through various aspects of what the Trust has been doing over the year, including the annual report and accounts. And so without further ado, I'm going to hand over to somebody who probably needs no introduction to you, which is David French, our Chief Executive. Over to you, David.
Thanks very much, Jenny, and good afternoon, everyone. I'd like to reiterate Jenny's welcome to you all, and I'd like to say thank you for taking the time to be at this session today and learn a little more about the Trust. So, although Jenny said I needed no invitation, I'm David. I'm Chief Exec. I was appointed Chief Exec on an interim basis in October 2020 and took up the role substantively in April 2021. And the highlights of the annual reports and accounts that we're going to cover today relate to the period April 2021 through March 2022. And what I'm going to do is just give a brief introduction to the Trust, a few facts and figures, then move on to some highlights and lowlights of the year, and in particular, what are the challenges for us going forward. And I'm then going to hand over to Phil Bunting from our finance team. Phil is the Director of Operational Finance, who'll give an overview of the finances for the hospital, and then to Serena, who will run through the quality report. And then we'll move on to a question and answer session as Sam described. So next slide, if you would, Sam, please. So who are we? University Hospitals Southampton. We are, I think, the 9th or 10th largest hospital in England. We're between 13 and 14,000 people, and we've a turnover of £100 million a month, £1.2 billion a year. So on a daily basis, we're consistently spending just over £3 million pounds a day. And we are simultaneously a local hospital for the local population, providing all of the services you'd expect that a district general hospital would expect. So if you fall over in the street, break your ankle, we will treat you. We have about 5,500 babies born here every year, and again, most of those are local folk. But what makes us different and what makes us special is that we're also a tertiary referral centre. So we're serving a broad population across the south of England, nearly 4 million people, and we provide the services that can't be done at every district general hospital. So neurosurgery, so if you have a brain tumour, for example, or complex cancer surgery. And that third bullet point there, one of only 2 major trauma centres in the south for adults and children. Practically what that means is if you are, for example, driving along the motorway north of Basingstoke and unfortunate enough to be in a big road traffic accident, the ambulance will scoop you up and they will drive past Basingstoke Hospital, past Winchester Hospital, and bring you here. And that's because we've got 24 hours a day, 7 days a week, 365 days a year. We've got the specialists and the expertise to deal with that complex, highly specialised work. We're a university teaching hospital, and that means we're very active in research, and I'll be talking about that later on, but it means that we're one of the highest recruiters of patients to research clinical trials in the UK. Thank you, Sam. A few more facts on our scale, and some of the numbers are sometimes jaw-dropping. So 160,000 inpatients and day patients going through our hospital, around 75,000 of which are emergency, the rest are planned and scheduled. We see thousands of people a day in our outpatient services, so more than 650,000 over the year. And in addition to that, we are also providing clinics in locations across the south. So we deliver quite a lot of outpatient clinics in Dorset, and indeed we go as far west as Plymouth. We're also up into Oxfordshire for some of our treatments. And then in our emergency department, we have more than 400 a day coming into the ED or A&E, you may know it as, and over the year that's 150,000. So I suppose that the point about this slide is there's a couple of things. One is that the scale of the place, which is just immense, but it's also a recognition that whereas for us these episodes are in many cases routine because we're doing it all of the time, we also, and I encourage all of our staff to remember that for the patients involved, this can be a once in a lifetime moment. We have the privilege of seeing people at their most vulnerable times, moments of tragedy, also moments of joy. And we've got to recognise that we are creating lifetime, whether we like it or not, we are creating lifetime memories for patients. So what is routine and run of the mill for us every day is absolutely not for patients. And we have to remember that in all of the encounters that we have across all of our people. Thank you, Sam. The values of the organisation are well established and well embedded. So I would say that if you stopped someone in the corridor and said, what are the values of the organisation, the overwhelming majority of people would be able to quote them because we talk about them all of the time. The first needs very little explanation. Patients first. We put the patient at the heart of everything that we do. The second one, working together, that really has evolved over time. If you go back a couple of years, what it meant was the hospital working together across teams and across an organisation of our scale. You can imagine sometimes that's easier said than done. But what that's evolved into, particularly over the last couple of years, is it's not just working well within the hospital, but now increasingly it's around how we work with external partners, whether that's in other parts of health or in education or across local authorities and charities and so on. So the whole of the NHS, not least UHS, is more externally focused, and we are trying to work across boundaries to integrate services better across health and social care. And that final one, always improving. It means how can we make today better than yesterday? And if we can do that, how about making tomorrow even better? So there's something culturally about how we go about doing that. It's recognizing that things don't always go right. And so when they don't always go right, we try and take a time to reflect on it and talk about it as a team. So we absolutely don't want to be brushing those things under the carpet. We want those issues to be raised for us to find out about them so that we can talk about them and do something about it so that tomorrow the same thing doesn't happen and we do better. And when we do, let's celebrate that. Thank you, Sam. So I characterised the year really as an up and down. So in the beginning of 2021, we'd had the quite devastating major COVID wave that had swept across the country, and we were still, as we went into the new financial year in April 2021, we were still really that wave was dwindling, but it hadn't completely gone. And what's happened since is that COVID has ebbed and flowed, but it has never really gone away. So we had been quite active in the infection prevention and control aspect, because it was really important to us that the infection didn't spread within the hospital, and that's called nosocomial infection. And there are many reasons why you want to minimize the infection. First of all, the mortality associated with the disease, particularly in those early Delta waves, the mortality amongst the frail elderly was in the 40% range. So we knew that spreading COVID within the hospital directly impacted on people surviving or not surviving. And even now, although mortality of COVID is more akin to flu, actually maintaining infection prevention and control practice is very important to us, because a patient who is medically ready to go home but has COVID will not be accepted by a care home. So that clearly has implications for our the flow within the hospital and getting patients out quickly so that the next patient can come into a bed. So even now, infection prevention is vital. And I think, you know, all credit to Gail Byrne, who's the chief nurse and our director of infection prevention and control, who's done a great job. When you look across the country at nosocomial rates and rank them, we are well into the top 10%. And again, back to my comments earlier about the mortality associated with COVID, particularly in the early waves, we know that being amongst the best in the country for nosocomial infection, we know that that saved lives, and I'm really proud of that. You might have seen in the news that Southampton was mentioned more frequently than you might expect, and more frequently certainly than other hospitals. So it was a doctor from this hospital that led the CovBoost study, which was the nationally commissioned study on which vaccines to use after the initial doses of either Pfizer or AstraZeneca. And actually, many of you might have had a COVID booster recently. Again, the choice of the vaccine, that was informed by a doctor leading that CovBoost study, and that's led the UK strategy and also strategy across the world. It's true to say that you know, working in the NHS through COVID and beyond is challenging and is hard work, but I'm very pleased to tell you that the staff survey results, which is a survey done across all NHS organisations across the country, places us in the top 5 or 6 in the country. So when you ask people, would you recommend UHS as a place to work, we are right up there in terms of the response from our people. And we know that when staff are satisfied and happy in their work, we know that that translates into better patient care, which is what we are all here to do. So although we have been very busy operationally, we have published a series of strategies which guide the decisions that we're making and setting the direction of travel across the organisation. I'll be talking later about the corporate strategy, but we've also launched strategies on digital, so our IT offering, sustainability and the green agenda, people and outpatients. And the development of our estate. We've spent over the last 3 years about £200 million on capital improvements across the site. The site is so vast that you might say, well, it hasn't touched the sides, but in the year we completed the expansion of our much-needed expansion of our ophthalmology department. So a fantastic new outpatient facility at the back of the hospital. We've renovated part and expanded another part of the emergency department, and that's really in recognition of the increasing numbers that are coming through every day. We've now got more space with better flow. The patient pathway journey is much improved. We've opened 4 new theatres, and Hanwick House is our new cancer facility, particularly for day case chemotherapy. It was in a very crowded area and is now in its own facility, again at the back of the hospital. That's a really far more pleasant and appropriate environment. Thank you, Sam. So areas of challenge. It is true to say that I think that right now is one of the most challenging times, certainly in our generation, and staff well-being is very important for us. So the cost of living crisis is real, and the majority of our workforce are really genuinely and practically impacted by this. So are worried about putting food on the table, worried about school uniforms for their children, and we're doing all that we can to support our people through that. There are clearly limits to what we can do as a public sector organisation, but under Steve Harris's leadership, I think we've stepped up and delivered what we can there. It's with regret I talk about the second bullet point on this list. In our emergency department in particular, we are seeing more violence and aggression and some really awful physical violence against our staff, which we think is completely unacceptable, and we will not tolerate it. And it says something, I think, about our society. It's a fact, and we are learning to have to deal with that. So it's how do we support staff? We've got security presence in the department. We've got better relationships with the police so that they're able to attend and support us. And again, with sadness, I tell you that staff are now wearing body cameras, which is a helpful thing. But it is a pity that we've needed to do that. And equality, diversity and inclusion. So a significant proportion of our workforce is not white British. And again, back to those staff survey results, we do see a difference between the staff survey results from people from different non-white British backgrounds. And again, we're trying to do all we can so that everybody, junior, senior, whatever your background, can feel part of this organisation and can thrive and be their best. Because we know that when people are their best, then patient outcomes improve. And then when people say to me, what are the big challenges facing the hospital? Clearly, after people, it's capacity within the hospital. So the hospital had a capacity problem before COVID. COVID has made that worse. So we've got pressure on waiting lists. We've got pressure on our ability to discharge patients from the hospital into social care. Elsewhere in health and social care, there is pressure too. So in general practice, I think it's well publicised that some practices in particular are struggling. We are seeing more people potentially as a result coming through into the emergency department. So capacity remains for us the biggest challenge, and Phil will talk in a moment about some of the capital investments that we've made to help address that. But it is certainly true that we've got an issue with the amount of physical estate capacity that we've got, the condition of that estate, given that we are predominantly a 1960s and 1970s estate, and then workforce. We are in a war against other employers. We're all trying to recruit the same people, and there aren't enough people. So how is it that we can make the NHS and UHS in particular the place where people want to come and work and stay and be their best? Thank you, Sam.
Hey, David, I think, is that your last slide?
I think it is.
Thank you very much. So I'm going to thank you very much for giving us that update on the performance over the last year. And I'm going to move straight to Phil Bunting, who's our Director of Operational Finance. And Phil's going to give us an update on the annual accounts. Over to you, Phil.
Thank you, Jenny. Hopefully everyone can hear me okay. So yes, good afternoon everyone. My name's Phil Bunting. I'm the Director of Operational Finance at UHS. I'm just going to take you through over the next sort of 5 to 10 minutes the key highlights and summary points from our annual accounts for 21-22. Before I do that, however, I thought it's always good to start by looking back and reflecting on where we've come from. And I think particularly for UHS, we've got a really successful track record with our finances. When you look at the 4 years prior to COVID, the Trust achieved cumulative surpluses of 90 million across those 4 years. That has been really valuable in terms of providing capital for investment in infrastructure, in facilities, and in the much needed capacity that the Trust has needed. COVID obviously hit in 2021 and has significantly changed the financial architecture within the NHS. For providers like UHS, we've moved on to block contracts predominantly. That does create a level of risk in that we have to therefore manage our activity within a block of money. As we've moved into 21-22, we've really seen a change of gear with that financial regime as well. We've seen a return of efficiency targets and a focus on restoration and recovery that was much needed as we've moved from that peak in early 2021 that David talked about to a period where we've had to live with COVID and get used to it as a normality. In terms of our financial position, therefore, it was a challenging year, but I'm really pleased to report that we did deliver a surplus for the year, albeit a small surplus. We had a break-even target and we reported a surplus of £48,000 for the year. We did that delivering an efficiency programme of 15 million and also achieving on elective recovery targets, bringing in £31 million for the Trust. We also grew in scale. So David mentioned some of the areas where we've grown and been able to increase in investment, particularly in R&D. And we now are of a size where we are £1.2 billion as a Trust. Also, our capital programme, we've had great success with regards to investment. Remembering that capital has been generated by those previous years of surpluses. We've invested in ophthalmology facilities, in theatres and in our ED department. Similarly, we've also managed to draw in external sources of capital that have been really valuable to the Trust, particularly around the green agenda and sustainability. Looking forward, it goes without saying that we are in a period of unprecedented financial challenge. Particularly the macroeconomic climate is not one that we've probably seen in previous years, certainly not in my career. Inflation poses a significant risk to the Trust, and with regards to our energy costs, looking at these as an example, our energy bill for the Trust this year will be 5 times the level it was in 2019-20. But we do continue to respond strongly to that challenge. We continue to exceed our targets for recovery in terms of levels of activity. The target for the Trust this year is 104% of 19-20 levels, and we are exceeding that. Similarly, we are on track to deliver our efficiency targets this year of 45 million. So despite the level of challenge, we continue to deliver and perform well, and we'll continue to look forward and hopefully deliver to our plan for 22-23 and onwards.
Phil, have you finished?
Yes, Jenny, thank you.
Thank you very much then. And so without further ado, I'm going to move straight to Serena Gorgruger-Woods, who's our Head of Clinical Quality Assurance, and Serena will take us through the quality report. Over to you, Serena.
Thank you, Jenny, and thank you for the invitation to come and talk today about the quality account. Sam, next slide, please. Can I move to the, thank you. So the quality account is part of the annual report, and it's a mandated part of the report. Every year, all NHS hospitals in England have to prepare an annual account and publish it so that the public has an opportunity to read about the quality of our services. It's obviously very, very focused on quality. It's called the quality account, obviously, and it makes us more accountable to our patients and to our public, and it also helps drive improvement in the quality of our services. It's also, in terms of the annual report as a whole, perhaps the more slightly human element as a read, because it brings together a lot of the information that the rest of the annual report presents, but gives them more context, contextualizes it more in stories, and an opportunity for us to celebrate what we have achieved over the year in terms of quality. It is mandated, it is a legal requirement, as you can see on the slide in front of you, but hopefully it is also quite an engaging read and the sort of report that our stakeholders, our public, our staff might want to dip in and out of and read from time to time to keep themselves updated. Next slide, please, Sam. So it's quite a hefty document, and it's got 4 elements to it. So the first part is a statement on quality from our CEO, so from David, and this sets out the focus of the quality account with the background of quality. It's a really good opportunity for us to present the kind of challenges that we might have experienced during the year in terms of quality, but it also enables us to explain the kind of positives that have come out of it and some of the lessons that we've learned, and as I said, it gives us an opportunity to celebrate the quality that we're able to deliver here at UHS. The second part of the quality account is a retrospective review of last year's quality priorities and a presentation of this year's priorities. It also includes statements of assurance from the board, and these are very much mandated parts of the quality account. They include things like national clinical audits, payment by results performance, data quality, data security, learning from deaths, how we perform with our freedom to speak up, guardians and work, and several other elements as well. I will return to the quality priorities in a moment. Part 3 of the quality account is an area that we have a little bit more scope on, that we can include some information that we would like to present that isn't mandated, and we use this at UHS as a section that we call our commitments to. It's an opportunity for us to celebrate how well we have done in areas that the rest of the quality account doesn't cover. So this includes things like how well we've performed in quality against in patient safety, research, education training, the environment for our patients and our staff, tech, digital areas. It's a much more lively read, and as I say, it's a really nice opportunity for us to be able to demonstrate what we have achieved. It also sets out what we're planning to do in the following year, so it allows us that continuity, so we can demonstrate that we're continuing to evolve, we're continuing to learn, we're continuing to share the learning, and that we're continually driving quality improvement forward. The very last part of the quality account is the annex, which is statements from relevant clinical commissioning groups, local health watch organisations, and overview and scrutiny committees. So this is the opportunity for our key external stakeholders to comment on how well we have performed in quality, and perhaps to give us some recommendations for the following year as well. Next slide, please. So just to focus a little bit on some of the type of information that's in the quality account, I'm just going to talk through the 4 quality priorities that we set in 2021 and 22. So the quality priorities are set through a consultation process. We use internal and external key stakeholders to help us to really focus down on what we think are the areas that if we work really hard on, these will make a significant difference. Obviously, we're working on quality all the time in many, many different ways, but these are some really key significant priorities that we can work hard on during the year and be able to show in our retrospective review the following year how well we've done. So the first priority in 2021 was the introduction of midwifery continuity of carer for women at risk of complications in pregnancy. So this is a model of care that aims to limit the number of different healthcare professionals a woman sees during her pregnancy, and it recognises that a close relationship between caregivers and patients based on a relationship of mutual trust and respect leads to better safety outcomes for women and babies, and it also offers a more positive and personal experience. And it incorporates recommendations set out in the Better Birth Report, which was published in 2016, which promotes continuity of carer for women who are at greater risk of complications in pregnancy and who experience poorer outcomes. So that includes, for example, women from Black, Asian and minority ethnic backgrounds, those who live under indices of multiple deprivation, or those with increased vulnerability such as poor perinatal mental health, history of substance abuse, history of domestic violence, areas such as that. For this priority, we did really well in 21-22. Our service was really quick to adopt the model. They had been working up to it anyway, so this was a really good area to put some resource into to help to move forward. We rapidly established 5 midwifery continued care of carers teams, with each team caring for their own caseload of women in the antenatal, labour and postnatal period, and we performed really well in terms of reaching women at greater risk. This work has continued on this year, really popularly adopted by our staff, who continue to work really hard on it, and it's been really, really well evaluated by our patients, who generally really value this as a model for their care during their pregnancies. So we did really well on priority 1. Next slide, please, Sam. Priority 2 was to support staff wellbeing and recovery. David has already alluded to this in his presentation, but the health and wellbeing of people and promoting a healthy work environment is one of the top priorities at UHS. And in 2021, we sort of appreciated that many of our staff were really mentally and physically exhausted after the demands of the first year of the pandemic, and we recognised that they'd need some time and some space and some support to develop resilience while the pandemic continued, and to be able to recover as pressures eased. We looked at all sorts of indicators of that, as well as talking to our staff, and we did notice that although our staff survey results had improved significantly in 2020, the proportion of staff reporting work-related stress by 2021 had really increased. So we knew it was an area that we needed to continue to focus on. So during the year, as you can see from the slide in front of you, all sorts of initiatives continue to be introduced. We actively listened to our staff, and we responded to their feedback by including more sort of in-the-moment support and directly in response to what they were telling us. We had more regular morale initiatives and created easier ways to access wellbeing support. We became more flexible and more responsive as the year progressed, and we provided a range of support and options tailored to the needs of the staff. And we also recognise that wellbeing is really personal, and anybody's approach to promoting and sustaining their own wellness can be different, and we were able to start to adapt to that. So staff wellbeing is really, really well embedded now in our UHS culture, and as David said, it continues to run through all of our strategies, our work streams, and really reflects our values as well. So again, we felt quite a success in priority 2 in 2021-22. Next slide, please, Sam. Priority 3 was managing risks to patients delayed for treatment and restoring elective programmes. So you can imagine the pandemic had a significant impact on waiting times as elective activity reduced, so that we could focus on treating patients with COVID. So, for example, pre-pandemic in March 2020, we knew we only had about 29 patients who were waiting over 52 weeks for treatment, but by March 2021, so a year later, this had increased to over 3,000 patients. So a really significant change had occurred during that pandemic period. And those delays clearly have a significant impact on people's quality of life and at times outcomes. So by 2021, there's a real imperative to move towards managing the pandemic while continuing to treat as many other patients as possible, and making sure we communicated effectively with those waiting to help manage the uncertainty and to reduce the backlog where possible. So a really difficult priority, I think, certainly not one that we were unique in, and one that nationally, as I'm sure you're all aware, everybody struggled with and continues to struggle with. However, we addressed this with real commitment and introduced priority initiatives, such as introducing a clinical prioritisation process that focused on prioritising all patients waiting and making sure that we had really good communication lines with them. We brought in a clinical assurance framework, which was designed to measure and mitigate risks across specialities, as well as ensuring that the resources that we had were allocated in line with anticipated levels of potential harm. So we worked really creatively on initiatives to try to meet this priority and to be able to move it forward. I mean, we didn't solve all the problems, but we performed really well against this priority and benchmarked well nationally against comparable trusts, and we're really proud that we managed to do things like maintain all our cancer services through the pandemic and offer virtual outpatient appointment and significantly increase the volume of diagnostic activity as the pandemic started to ease. It's no secret that RTT work is really challenging and continues to be so, but keeping this as a priority helps us to focus on that during the 2021-22 period. Next slide, please, Sam. And the last priority that we set during this period was reducing healthcare associated infection, and I don't think that's any surprise to anybody. It was a real key area, obviously, and again, David has already commented on where we performed in this. So despite the pressures, we performed really well for in-house transmission of COVID. We've performed really well against MRSA metrics and for bloodstream infections. Our C. diff performances weren't quite as good, but that was reflected nationally, and it's probably due to high use of antibiotic use during the pandemic, but considering the situation we were in, we were really proud that we had performed so well against this priority, and again highlighting this priority was one of the ways that helped us to focus on it and also to be able to review it retrospectively and show our public how well we had done. Next slide, please, Sam. Thank you. So just to show you the quality priorities that we're working on at the moment, so the 2022-23 priorities, these we had the opportunity, because things had calmed a little bit when we were setting our priorities this year, to go out to a much wider consultation and bringing people such as our staff, more external stakeholders to help us set these priorities, and we actually have come up with 8 priorities this year, which is a more typical number. The last 2 years during the pandemic, we haven't been able to hit quite so many, so we're really pleased to have got to the point where we feel we're able to focus on a few more priorities this year. So very briefly, enhancing capability and quality improvement through our always improving strategy is our first priority. This is going to underpin everything else. We really want to focus on developing a culture of kindness and compassion to drive a safety culture, and that reflects a national initiative as well. We would love to improve mental health care across the trust, including support for staff delivering care. This has been highlighted particularly by the staff as a real area of concern for them that they'd like to see improvements on, and recognising and responding to our deteriorating patients, which is building on work that we have focused on year for probably the last decade now. Thank you, Sam. Next slide. Number 5 is improving how the organisation learns from deaths. 6 is continuing to roll out shared decision making. We have a really strong focus on that at UHS. A lot of commitment from our staff, which is great. 7 is work with our local community to expose and address health inequality, something that we've not really put as a priority before, but I think the last few years have really shown us is an area that we need to be bringing to the forefront. And again, our staff are really committed to delivering. And the last priority for this year is ensuring patients are involved, supported and appropriately communicated with on discharge. Discharges can always be a challenge. Most years there's something in our quality priorities about discharge, depending on the context of what's going on during that year. And last slide, please. I think that was it. Lovely. So as a really quick gallop through what the quality account is, hopefully some of you have been able to have a look at it, and if you haven't, it may be a document that is worth dipping in and out of just to get a real feel for the human context behind the annual report and see the kind of work that our staff managed to deliver despite the pressures that we're under at the moment. And that's it. Thank you very much, Jenny.
Thank you very much, Serena, and I'm sure all the members on the call found that a really interesting trot through the quality and performance information. So we are actually going to go to a Q&A slot now, and the people that have already spoken, which are David, Phil and Serena, are going to be joined by Steve Harris, who's our Chief People Officer, and Gail Byrne, who's our Chief Nursing Officer. Some of you have already been posting questions in the Q&A box, so I will go to those. We also had some questions submitted beforehand, so I'm going to try and cover as many questions as we can. We've actually were due to finish this bit at 2:45, so let's see how far we can get in about 8 minutes. Let's see how far we can get with questions. Anything we don't answer, we'll be able to pick up afterwards. So I'm going to go to one of the first questions that was posed, which was around borrowing funds from private lenders. Phil, do you want to pick that question up?
Yeah, happy to take that one, Jenny. So I think the question was around borrowing, which was mentioned in our strategy document, and what's our approach to that. So in response, I think firstly, just to make clear, so we're always very careful in sort of making decisions when it comes to borrowing. We're in a fortunate position as a trust that actually we have quite significant cash reserves, and we look to use our internal funding before we seek any borrowing options. If we did look to borrow or finance for any sort of initiative, we do have quite thorough processes internally we go for in terms of conducting financial appraisal and making sure there's a payback on any borrowing costs and that we'd cover those borrowing costs in full. But as I said, it's not something that as a trust we tend to go into in a significant way. Borrowing isn't a big part of our sort of financial model, and certainly not one that we're sort of looking at as part of our future financial plans as well.
Thanks very much, Phil. David, I'm going to move to you to a question that John Chandler put in, which relates to a league table that was published in the Daily Mail today, reference bread blockers, but I think John is referring to the no criteria to reside, which is how it's referred to at the moment, and which obviously links to care packages and everything. David, are you happy to do a response to that?
Yeah, so I think the article in the Daily Mail had a list of who are the top 10 hospitals with the largest number of patients who were medically fit and ready to go home if they could be discharged. Unfortunately, what we've got there is a list of the 10 biggest hospitals. It wasn't expressed as a percentage of the bed base. So that's not to say that we haven't got a problem, because we absolutely have, but this hospital is no different from other hospitals within Hampshire and Isle of Wight. And in turn, Hampshire and Isle of Wight is pretty consistent with the rest of the country, a little bit higher, but not a crazy outlier. Just to give you an idea of the scale, so we've about 1,000 adult beds, so I'm excluding maternity, I'm excluding the children's hospital, and currently we have circa 200 people that we would describe as no longer meeting the criteria to reside in hospital. In other words, they're ready for discharge, typically to social care, care home, or back to their own home with domiciliary care visits. So you may say, well, why have we got this problem? It's certainly true that the social care capacity in the country, both domiciliary and care home, is lower than what it was a couple of years ago, and that's about the availability of labour workforce. So those employers are competing in the most part with fairly low paid other employers. So Tesco and Aldi have recently announced pay increases that will increase the care home workforce pressure. So what are we doing? We're working far better across the integrated care system. So that means alongside Hampshire County Council and Southampton City Council, we've piloted a couple of things to see whether they would work. So over the last 6 months, we set up a care hotel. So we between us basically took over a Holiday Inn and brought staff in to care for patients there, thus taking them out of the hospital. Actually, our conclusion was that we couldn't make it work, and it was a really expensive model. So we have pulled the plug on that, and we are still, I'd say, really challenged on the our ability to discharge, but it is the #1 priority across the health and social care conversation right now. I think when you talk to local authority colleagues, what they'll say is that their financial budgets are facing a cliff edge, and so there is a question about the affordability of local authorities to be able to pay more for care home capacity and more for domiciliary care. So that, I don't think we have a solution to that at the moment, but it means that they're not able to compete with the likes of Tesco and Aldi, and hence at the moment capacity is lower than it needs to be. Absolutely.
Thank you, David. And Gail, I'm going to go to you next. There's a question around the Health Foundation report on attrition rates for nurses being as high as 25%. And the questioner wants to know, is this an issue for us at UHS? And if so, what are we doing about it?
Yeah, I think it's a very pertinent question, Jenny, in terms of nursing and actually the thought that the attrition rate is high and it's likely to continue. So in terms of what we're doing locally here at UHS, we have got an attrition rate about 11% at the moment, and our vacancies for nursing, registered nursing, are 8%. And actually, when I joined the trust in this role way back when now, we used to see really significant vacancies of up to kind of 40% on some wards in terms of registered nurses. So to a certain extent, we are in a better position, and that's because of recruitment, but also retention. And it's a complex business, and I think that the things that the board have supported is apprentice nurses, so training our own. We are very active in training and education because that's something that leads to retention. And we also, with Steve and the OD part, make sure that we look after people's well-being, which is another reason for retention. And Serena was right when she mentioned in the presentation that we're seeing more staff with stress and anxiety. And I think that that is something that we need to wrap around our staff in terms of their well-being. And one of the mantras I have is putting your own oxygen mask on first. I think we've got part of the nursing family is healthcare support workers, and we do see a higher attrition rate with them. There, and obviously some of the stuff that David was saying, talking about in terms of pay for people who could go and work in a supermarket as opposed to working on the wards. But again, we've got some really good interventions. We've got a kind of landing ward, we've got an HCA, a healthcare support worker hub, and we've got facilitators in terms of ensuring that when people come in to work on wards, that they have an expectation of what is going to be expected of them as healthcare support workers, and that we have lean in to them. And that actually is paying dividends. So the final thing I would say is that we've done a lot of overseas recruitment. We're very careful about how we manage that and how we land our overseas staff into the organisation so that they really feel a part of UHS. And one of the things that I think it's really challenging, but you know, I believe that leadership is the key. I've done a lot of talent management of my senior nursing team and matrons, because that has an impact on how people feel about the place. And the thing I would say I was proud of is our UHS nursing family, because whilst it's challenging and you may be in a hole that's we'd be better in this hole than anywhere else. So yeah, hopefully that answers the question, Jenny.
Thanks very much, Gail. And you referred to retention as an issue. There are some questions on retention. So Steve, I want to give you an opportunity to add anything that Gail said.
Yeah, sure. Thanks, Jenny. Just noticing, John, again, a really pertinent question in the chat around things that we're doing. I mean, Gail has outlined a series of the measures that we're taking around retention, but there's obviously something more pressing that our people are facing at the moment, and that's the cost of living crisis. And I think I'm really proud here at UHS of the actions that the board have supported here for our people. So there's a range of things that we've done to try and make life here easier, particularly with the challenges that people are facing. First of all, we've put in at 60% discounts in our restaurants in both SGH and PAH, which has gone down really well with our people and enabled people to get access to hot food and hot meals at a really discounted price. We've partnered with, we have a benefits platform that we have for our people called Vivat, which offers a huge range of benefits for our staff in terms of discounts for supermarkets, etc. We have set up a hardship fund for our people, so those that in most need can access this, and can also access things like free food and referral on for food banks, etc. We've discounted the cost of our nurseries. I mean, those people will have noticed at the moment that the cost of childcare is a particularly challenging issue, and there have been national rallies in London to the tune of how difficult this is for people, and we made the decision to reduce our nursery fee. So there's a range of things that we've done for our people, as well as general health advice and support around this. And you know, I think it's been really well received by our staff. It doesn't solve all the challenges that we've got, and obviously national pay, for example, is something that is out of our control, but we think that this has made a real difference to people and will continue to make a difference to people moving forward.
Thank you very much, Steve. And I'm going to move on to the last question for now. We may be able to pick up some more when we get to the next Q&A slot. But a really interesting question from Catherine Barber, which was, if we had an extra 10% in the budget, what would we do with that? And I'm going to come to you as Chief Exec, David, to give you the opportunity to dream for a bit.
Yeah, Catherine, so you should make the cheque payable to universities. I mean, in all seriousness, the chance of us getting at the moment 10% more money is somewhere between 0 and nil. Okay, so let's just be realistic here, given the state of the country's finances. What would I do with 10% more money? I feel that if we had more money, I would want to do more about the cost of living crisis for what I would describe as the majority of our staff, who are worried about putting shoes on kids' feet, food on the table, heating the house. I feel that there's enough pressure about working in the NHS, but to add that personal stress into the mix is unhelpful in the extreme for both the staff and the implications for our patients. So I want to put more support into that. I think as well, I would want to go faster on transformation. So we are trying at the moment to balance our resources between doing the best we can and fixing stuff for the future. So our IT systems, they're good relative to the rest of the NHS, but clearly we could do more. We've got more to do on making our theatres more productive, more to do on our outpatient and scheduling systems, again, to make us more efficient. So those investments would make us efficient over the long run. Phil mentioned in his talk the cost of energy has gone up by 5 times. This is predominantly a 1960s and 1970s estate with the kind of energy performance that you might expect from a 1970s house and 1970s car. So the cost of doing something about that is immense, but again, the rate of return that we would get on that would be huge. And it's about creating that return so that we can invest that in patient services. If we invest it all in patient services now, we've still got the problem of energy consumption. We've still got the problem of that lack of transformational horsepower that we'd need to address first. I don't think in terms of patient waiting list, which is the other sort of flashing light on our scorecard, there is a lot that we can do in the very short term, absent more people and more buildings. So clearly some of that extra 10% would need to go there as well, but it's about balancing the short and long run, I think.
Thank you very much, David. And I'm going to stay with you and bring you back to reality now and ask you to take us through the strategic plan and the progress in our journey to world-class care.
Yeah, thanks, Jet. And I'm conscious that we're a bit over time, so I'm going to try and do this bit a little quicker than before. So bear with me, but I'm going to try and run quite fast. Next slide, Sam. Just some context here. This was created. Our strategy was created in May 2021. We were just coming out of COVID. We recognised that as we came out of COVID, the organisation's head would come up and we would say, right, where next? What are we aiming for? So this was intended to be help with that question and to create a direction of travel and a North Star, if you will, that we could follow over the next 5 years. It's based on our very well established values that I talked about earlier there at the bottom, and then 5 strategic themes. And what I'll do is run through those themes very quickly and then give some practical examples of the improvements that we've made so far on our journey to 2025 and our vision of world-class people delivering world-class care. The strategy is on the website, and I'm hoping that we can get, if someone from comms could just stick a link into the chat where people can access it. It is deliberately quite a direction of travel. It is not a detailed account of exactly how we're going to do stuff. I think in an organisation of 13,500 people, you can't do that. What you have to do, I think, is paint a picture of the future and then challenge them to say, what does that mean for your service? What does it mean for your function? And for them to come up with the ideas. And that's the mode that we're in right now. And in fairness, the organisation is responding really well in very difficult operational times at the moment. Next one, Sam, please. So the first of the themes, back to patients first. So it's about patient outcomes, patient safety, and patient experience. And probably what is a change for us, and that, you know, the patients first has been part of the UHS DNA for some time. What's different about this is the strengthening our national reputation. Our house style previously was to kind of be a little bit under the radar, and I think we're now trying to be a little more out there, recognizing that a positive national reputation helps with patients' confidence in us. It helps with recruitment of staff that we're fighting to recruit against other organisations, and a strong national reputation with the NHS in London is more likely to attract investment. So we're more actively trying to manage that reputation in a positive way. Next one, Sam, please. So first one, patient safety and quality partners. That's bringing people right into the heart of it rather than it being a hospital business, bringing external folk in. We've done that. It's working really well. And we're also just starting on the implementation of actually a national patient safety framework, really trying to change the culture of what sometimes in the NHS, when you make a mistake, it's about blame and what did you do wrong. And this is going to be more based on the model of what you see more in aviation, which has been really successful at improving safety. And it's not about blame, it's around how systems, processes work together to improve safety. And we'll be working on that quite intensively over the next 12 months. Some nice examples of shared decision making, again trying to move away from the doctor knowing best and telling the patient to it being an informed discussion about what the options are, and that the option might be no treatment. You know, sometimes the symptoms and the side effects of treatment are pretty awful, and it can be perfectly appropriate that a patient chooses not to have treatment, but that's more and more a conversation between the doctor or the nurse, the clinician, and the patient. And our Chief Medical Officer, who's not on the call today, is a brain surgeon, and he's leading the way in his practice in how those shared decision conversations with patients are going on. Outcomes. We've put a lot of effort into publishing our outcomes, and you may have seen in the news, our bone marrow transplant was rated first in Europe. And if you look at our survival rates in our intensive care, particularly through the COVID period, we were the strongest in the country by some distance. So some really impressive outcomes. And we're publishing those against the overwhelming majority of our services now. Thanks, Sam. As I said before, we're a university teaching hospital. Why does it matter? We believe that being a research active hospital correlates with better outcomes for patients. Why is that? Well, we offer more access to cutting edge clinical trials for patients here, and also when you are research active, you tend to attract the best clinicians because they want to go to organisations that are pushing the envelope, pushing the frontiers forward. Thank you, Sam. So we've been very successful in the last 18 months in receiving external investment. So of that 35, 25 is from the Biomedical Research Centre, and we've had that funding announcement quite recently. Overall, as you might expect, the total investment from the National Institute has gone down. A sad reflection again of public finances, but the investment in UHS went up, and that's a good vote of confidence in us as an organisation. We've established a couple of centres, so setting up the infrastructure for that R&D, and we've also set up a research leaders programme. So before I mentioned the CovBoost trial, Professor Saul Faust, this is about how do we train the next generation of Professor Fausts, so that in 5 or 10 years time it is them that's on the Today programme and on the BBC News every other week, and we are funding time for our consultants to get involved in that. And it's another reason why, if you are a newly qualified doctor, it's why you want to choose UHS as the place where you work. Thanks, Sam. People, it goes without saying how important people is. It's been a theme throughout this this session. In effect, this comes down to how do we make people want to join UHS, and then once they are here, no matter whether they're junior or senior, whatever their background, where in the world they're from, is that they feel part of the family and can thrive and be their best, develop to who they want to be. Thanks, Sam. So we have a document that Steve and his team have pulled together. We talk about thrive, excel, and belong. And I haven't got time to go into the detail of the actions that are behind that, but there is an awful lot. You may have seen around the city the branding that we've done around recruitment, talking about UHS being a bit different, leading the way. We're not just the average hospital. We're UHS doing some really interesting and exciting things, and actually that is yielding some very positive results. Over the last year, we've recruited more than 700 more employees, again trying to get on top of those waiting lists, predominantly from the UK, but also from overseas, as Gail mentioned, and apprentices too. Thanks, Sam. Networks and collaboration. You'll recall that earlier on when I was talking about working together, how that's evolved from working together within the hospital to working in a broader group across health and social care. And in fact, now we've an obligation, and it is a requirement on us to collaborate with partners. So the architecture of the NHS has changed from independent, sovereign organisations looking after themselves and competing with each other for patients because patients brought money. It is now about organisations working together in a collaborative way to marshal collective resources across geographies, and for us that's Hampshire and Isle of Wight as our integrated care system, marshalling our resources to provide better services for the patients that we serve. Thanks, Sam. So some examples at a very local level. We've set up a forum with general practice, so GPs across the patch, and we've tackled some really practical stuff, like what gets in the way of us working together. So that has led to changes in how we do discharge summaries back to GP, how we do clinic letters back to GP, and that's helping with first of all the pressure on primary care. I think it's helped with that, but it's also reduced the number of inappropriate referrals, because we're providing GPs, general practice, better access into people here through a phone call, for example, rather than a letter that comes with a referral that generates work. And it came up in the question around delayed discharges, so working between health and social care. So it is certainly true that we have now got much better visibility on the issues that social care are facing, and the issues that we've got here. So some of the schemes that we've implemented, and we've done this really well with Southampton City Council, probably better than with Hampshire County Council, is how do we get the patients out in order to assess them? So discharge to assess, rather than doing the assessment while still in the hospital. It's all about working with those partners to get patients out of the hospital and into the most appropriate setting for them. I won't go into the details of every of all of the bullet points, except for one, which is the pathology network. So across not just Hampshire actually, but trusts in Dorset and in Salisbury, we've now got common pathology testing kit. We've got money for a common computer system, so that we can see their results, they can see ours, and a test done in Southampton is exactly compatible with a test done in Poole Hospital or Salisbury Hospital. That's a big step forward for us, and what it's enabled us to do is to consolidate the specialist testing that previously was getting sent by different hospitals to different places. All of that is now being done in Southampton, which is good for this hospital, and it's actually good for the NHS as well, because it's saving the NHS money. Thank you, Sam. Foundations for the future, which is really how do we establish a corporate infrastructure that's fit for the 21st century, recognizing that a lot of the estate that we're working with and systems are not even 21st century, they're mid and late 20th century. So it's around the physical estate, the condition of the estate in particular, and the capacity of the estate, but also our HR systems, our finance systems, and IT itself, particularly on IT clinical systems. It's also recognizing, I think, more than ever, recognizing that we are not just the larger employer in Southampton, we are the largest employer in the region, and we have a responsibility to the community that we are based in to help with the development of particularly the deprived parts of our community, and we're very active in that space. And the green sustainability agenda, I think that the attitude of society is changing quickly, and we're probably a little, in fairness, late on that agenda, but we're trying to catch up in terms of making the site greener and making the work that we do more sustainable from an environmental perspective. A couple more examples, Sam, on the next slide. The starting point for this is you do have to have money. If you don't have money, it means you cannot invest in your future. So for this year, we have the majority of our efficiency improvement plan in place. So we're at least 3/4, and the trajectory there is really good. That's a building block, because without money you can't do anything. We've opened Adanac Park, our off-site park and ride, and we're developing now the innovation campus there. There'll be buildings going up there that free up a space that previously work being done at the General will now be done at Adanac Park. And we've also done some initiatives at the General, particularly in theatres, which reduce our nitrous oxide emissions. So good stuff there. And then finally on IT, it's always a challenge when we've got operational pressure. Is do you open some more ward beds, or do you invest in new IT systems that will make you more efficient and productive going forward? I think we've delivered an awful lot in the IT agenda on a bit of a shoestring budget, and indeed some of the systems that we've created here are being sold to other organisations across the country. So some really impressive work by the IT team. I think then just to the closing slide, Sam, please. So an ambitious 5-year strategy for the organisation. As I said, it was written before or without having the benefit of the crystal ball that would have told us what was going to happen with public finances, workforce shortages, and the cost of living crisis. But those things are certainly making implementation more difficult. But I think I and the board remain completely convinced it's the right thing to do, and we are completely committed to delivering on this strategy to improve the services that we provide here, and the satisfaction that staff get from helping patients in the way that they do every day. Thank you.
Thank you very much, David. And sticking on one of those themes that you talked about towards the end around the balance and having to make decisions around more beds or investing in IT, one of the questions we had earlier was around how many additional beds we have planned for the winter. So I wonder, Gail, if you would be willing to come in and answer that for us, please.
Yeah, sure. Thank you, Jenny. From actually, we've got additional beds open at the moment. So we are having inpatients in our surgical day unit. We're up to 24 in there. We've got a surge unit in AMU or CDU out of ED. And we've also got some beds, inpatients in cardiac cath lab. So we've been having our winter planning meeting. We've looked at escalations. You're quite right to talk about staffing levels whilst you open up additional areas, because that creates a further staffing need. We manage it through a kind of our daily staffing hub, but also we manage where we escalate to and what is the next step in terms of staffing. So, you know, we were already there to a certain extent, and of course there are times then you have to cancel elective activity when you're in the midst of peak pressure, and it's a balance of those judgments about risk at every time. And then evidently we also would use bank and agency and make sure that we have the right registered nursing ratio in our areas. So, you know, I suppose if we do get overwhelmed, we've got plans in the back pocket if we do get overwhelmed. And the thing for me is about also the management of flow that David quite rightly mentioned earlier. So the earlier you can discharge somebody in the day, the better the flow is, and the more that you can look and actively manage their discharge, then the better that is. So looking at things that we can do within our control, and some of those things, like the medically optimised for discharge, aren't within our control, apart from making sure that all the forms are completed and filled in appropriately. So I think the we have got a robust winter plan, and you know, we're ready. We're ready. Thanks,
Thank
Jenny.
thank you very much, Gail. And Helen, I'm going to come to you for the member update.
Thank you, Jenny. Hopefully you can all hear me. Good afternoon, everybody. I'm a governor as appointed by UHS from the recently formed Hampshire and Isle of Wight Integrated Care Board, and I'm honoured to be the current Deputy Lead Governor and speaking to you today. So I'm here just to give a brief update on membership and activities undertaken. Sam, do you want to go to the next slide for me, please? Thank you. So how do members make a difference? So the events and membership team connect UHS members with different departments across the trust so they can contribute by using their experiences and make UHS services better through surveys, focus groups, play their part in the groundbreaking research which has been talked about, or by volunteering to help improve the experiences of patients and visitors across all of the hospital sites. UHS needs members to help spread the word, particularly when services are under pressure. Members are informed when the trust is under severe pressure and are provided with information that they can spread across our local communities. For example, in July, when the emergency department was experiencing delays of up to 12 hours, UHS advised members to use the Urgent Treatment Centre for non-life or non-limb threatening injuries, or use 111 for health information and advice, rather than coming to UHS. Members were encouraged to share these messages on social media, so thank you for those that did. Members play a significant role in shaping the governance of UHS by electing the Council of Governors. This year there were 13 seats up for election across the four public constituencies and 2 staff constituencies. And the Trust, I'm delighted to say, now have a full Council of Governors who are there to ensure that services are meeting the needs of the local community. The main role for the Council of Governors is to advise the Board of Directors of the views of the membership community, comment on the development of strategic plans for the hospital, and act in the trustee role, making sure the hospital meets its obligations. Thank you to all of the members, both public and staff, who voted in this year's elections. Members can also make a difference by telling their governors their views from the link shown on the slide. This gives you a voice at the highest level within the organisation. Thank you, Sam. So in terms of membership engagement for 21-22, so due to the pandemic and adhering to social distancing, there were limited opportunities for face-to-face interactions and participation at community events, but the Trust was able to connect with members digitally. So in April 2021, a virtual event series was launched exclusively for members, with the aim of equipping participants with the right facts and information from healthcare experts they could trust. This was particularly important at a time when there was a lot of misinformation online about COVID-19 vaccinations and testing, and at times when restrictions were starting to ease. These sessions gave vital insight from experts such as Professor Sol Forst, who has played a leading role in the National COVID vaccination programme, and Dr. Nitin Mahobia, the UHS Deputy Director of Infection Prevention. Members have said that these events really helped to get the correct information from professionals, empowering them to be a voice for key healthcare messages with the community. Several other non-COVID related events were also held, looking at other topical issues such as digital healthcare, patient data and patient participation. Written post-event reports breaking down the information were produced and sent to everyone who had registered. Throughout the year, the membership team and Experience of Care team encouraged members to take part in listening focus groups, which help shape services, thus ensuring the patient voice is heard in the co-design process for improvement. The Trust's Always Improving strategy sets out the ambition that patients will ultimately lead improvement across the Trust, and these groups are a way in which members can make a tangible difference to the hospital services they use. For example, in the past, patients living with diabetic eye disease were given information about their condition through leaflets. The patient focus group suggested the information would be far better presented in recorded videos, showing others what's involved in the process. These videos were actually produced by the members of the group themselves, so got to the heart of covering what patients needed to know. To keep members informed, the bi-monthly digital newsletter exclusively for Trust members was relaunched as Connect. This is a more interactive format. This gives updates from teams across the hospital, as well as details of projects that members can get involved with. Next slide, please, Sam. So activities so far this year. The virtual event series for members continued into the new financial year by commemorating the 50th anniversary of the partnership between UHS and the University of Southampton. This was a great opportunity to look back at the last 50 years and the impact of research in Southampton on the wider population, and to promote how to get involved in future projects. There was also a big effort to encourage people to stand in this year's Council of Governors elections through social media and patient groups such as Healthwatch. There were sessions on Teams for those who are interested in standing to find out more about what the role involves and expectations of the Trust Governors. This year, 26 members put themselves forward to become a governor across the 6 constituencies, which had seats up for election. As previously mentioned, there are now 13 newly elected governors who will bring a wide range of skills and experience to the council for the benefit of the Trust. Relaxed COVID-19 restrictions meant that over the summer, the Trust could take part in some big community events in Southampton for the first time in 3 years. This year, there was a Trust stall at the July Mela Festival, which is a celebration of South Asian culture. In August, Southampton Pride, and at the University of Southampton and Solent University refresher events. As well as promoting Trust membership, the membership team worked closely with other hospital teams, using the stall as an opportunity to engage the public on a number of initiatives, including recruitment, getting involved in research, the Trust Patient Support Hub, and a recently launched prostate cancer self-referral service. The stall also gave information on where people should go if they needed to access healthcare depending on their specific conditions. Thanks, Sam. So coming soon, you may have seen in the most recent newsletter, over the winter the Trust will be engaging with local people with a community roadshow. Members of the public can come along and they can ask questions about the services the Trust delivers and share their experiences and find out what UHS can do to support you. Starting this month, these sessions will take place in libraries across Southampton over a 12-week period, with a view of extending the roadshows over a larger area across Hampshire and the Isle of Wight in the new year. The virtual events will also continue over the next few months, focusing on specific conditions. When the public members were surveyed earlier in the year, they wanted to hear more about topics such as diabetes and cancer. So this upcoming series will be an opportunity to hear more on these areas from trusted experts within UHS. And as always, members will continue to be kept up to date on how they can get involved at UHS, whether that's taking part in listening projects, clinical trials or volunteering through email and bi-monthly newsletter. The membership team will be in touch with more detail on what's coming up in the next few weeks and months. And final slide, please. Thank you. So please do get in touch via the following links, as your views and participation are very much appreciated and valued. Thank you very much. That's all from me, Jenny.
Thank you, Helen, and for finishing your slot on time, even though you started a bit later. So thank you very much for that. And I'm really just going to make some closing remarks and bring us to a close. So I think the information that Helen just took you through exemplifies how important we view you as members and the role that you play. And that's in several ways, really. So apart from the various events and things that we've had, part of the reason that we've held this annual meeting is to keep you up to speed with how the year's been and how we anticipate things to be moving forward. So you heard about our vision to deliver world-class care by world-class people. You've also heard about us being on an always improving agenda. You've heard about the broader NHS challenges and got a perspective on what that means for UHS in terms of both our experience and how we anticipate that to impact moving forward. David was able to re-emphasise just the scale, I guess, of the issues for UHS, being the 9th or 10th largest hospital in England. And it does mean that many of the things that you're hearing about the NHS are replicated or duplicated or triplicated for us as UHS just by the sheer scale of our size. But that also brings with that some opportunities. And some of those opportunities, again, you heard that we don't just focus on delivering kind of local health services, but we also do the tertiary stuff, some of the bigger stuff across a much broader region. That means, because we are seen as exemplary in some areas, that we can attract staff. That's not to suggest at all that the staffing, that we're not experiencing staffing challenges, and Gail and Steve actually pointed to those, but it does mean that it has enabled us to recruit and retain some excellent staff, and you heard, for example, about something like Sol Forst. So what is the members annual members meeting about? Well, it's our way to interact with you as members, for you to hear what's going on, the opportunities and the challenges, and it also enables you to be able to speak on behalf of the Trust with the broader general public. We I think covered most of the questions, but the team will go through to make sure that anything that hasn't been answered, we will answer. So you will get those responses. So please don't worry if you feel that your question wasn't answered, particularly if you provided a Q&A beforehand, those will be picked up. I also picked up the point that I think it was John that made around the Q&A slot being too short in the scheme of the afternoon, and we will take that feedback back and then think about that for the next session that we have with you. As Helen's just said, this is an ongoing process, so there's various events coming up where we will expect to interact with you, so we do look forward to working with you over the next year, when we'll of course come to do the next annual meeting next year. Just before we close, I do want to thank a number of people that without them this afternoon wouldn't have been possible. Firstly to Sam, who opened up for us, and the team that worked with and supported him in making today and managing today. So that's Helen, Karen and Stephanie. And then also a big thank you to all of our speakers that contributed today and did the preparation and the work beforehand to make sure that we could bring you as up to date and interesting inputs as possible. So thank you very much for giving us your time today. Thank you very, very much for being members. Please continue to support and promote us so that we get more membership growing. And we look forward to seeing you over the next few weeks and months as we go into the winter and beyond. Wishing you all a good afternoon, and thank you again.